of stomach. Mainly, we are going to the deeper sessions, like which are the complications or the major surgery procedures are needed in the disease of stomach. So already I have last class I discussed about peptic ulcer, that is that duodenal and gastric ulcer. So in that one complication was peptic perforation. So, perforated peptic ulcers. It is a terminology used for the perforation of the both duodenal ulcer or gastric ulcer or stomach ulcer. The clinical features and management are similar. Perforation is common in duodenal ulcer. Mostly 75% of perforated peptic ulcer comes as duodenal ulcer perforations. But the mortality is more in gastric ulcer perforation and perforations in the elderly. So first of all, a perforated duodenal ulcer. It is common in males, that is 8 is to 1 ratio is there. Mostly it is common in 35 to 45 years of age group, but can occur in any age group also. Mostly anterior ulcers perforate commonly. In 80% of cases, there is history of chronic duodenal ulcer. 20% cases silent perforation, that is the symptoms may not be that much severe or chronicity is not there. Then mostly the perforation can occur in an acute ulcer or in an acute presentation of a pre-existing chronic ulcer. Perforations may be precipitated by steroids, analgesics, NSAIDs, then alcohol or anti-malarial drugs. Overall incidence is 5%. An active ulcer perforates commonly. Already told active ulcers either acute or in an acute in chronic ulcer. Then so symptoms how it will be the perforation which results in the peritonitis. So you have to write about the stages of perforation that is the peritonitis stages or itself. That is first stage is stage of chemical peritonitis. So once a perforation occurs, the stomach contents escape into the peritoneal cavity. The acid from stomach causes chemical peritonitis, leading to the severe pain in the epigastric region, and there will be vomiting, tenderness, guarding, then muscle guarding, rigidity, tachycardia, and sweating. So, in that chemical peritonitis already, and just after the immediately the perforation is occurring, the gastric and duodenal contents leak into the peritoneal cavity. So, what it will be having the symptoms of severe agonizing pain in the right hypochondrium. Mainly, already told, the gastric content is mainly causing. So, HCl, which is producing pain. There may be episodes of coffee ground vomitus followed by melena later. The pulse rate will increase, the patient will be pale and anxious. Blood pressure may be normal in first few hours. Per abdomen, there will be muscle guarding and rigidity of the abdominal wall. Rebound tenderness is present all over the abdomen. This sign is called Blumberg sign. On percussion, liver dullness is obliterated because of the collection of free fluids or free gases under the right dome of diaphragm. So usually it occurs for about 2 to 4 hours from the time of perforation and the bowel sounds usually absent. So this is called the stage of chemical peritonitis. Second stage, it is a stage of reaction. In this stage, actually it is also called stage of elution or stage of dilution. Why? Because the peritoneum secretes a lot of fluid to neutralize the escape contents. So as a result of this HCl and the bile which is released from the gastric or duodenum is diluted by the peritoneal secretions. So it is because of the that insult it is having, it is the reaction of the peritoneum resulting in improvement of the symptoms as the neutralization of HCl and bile is happening because of the peritoneal secretions. There will be temporary the pain reduces and the patient feels better. So it is called the stage of dilution or stage of elution. Mostly it lasts for 3 to 6 hours, but then the signs are, so these are the symptoms. So the patient will feel that it is normal, but we get the signs are worse. What are the signs? Pulse is feeble, more than 120, feeble pulse, but the tachycardia because of the pulse, the volume is less, but the number is more. Okay, 120 per minute. Hypotension persists. The evidence of dehydration due to loss of fluid into the peritoneal cavity. Then shifting dullness is present. Abdominal distension is due to fluid and paralytic ileus. Then bowel sounds are absent, guarding and rigidity are worsened. So you can see that all the symptoms are reduced, but the signs are increasing or are positive. Next, third stage is the stage of bacterial peritonitis. So once the peritoneal content gets contaminated with a gram-negative bacteria, resulting in the bacterial peritonitis. That is, the organs are from the intestine itself and not from the peritoneum. So these intestines are causing contamination of the peritoneal contents. So patient then suddenly become severely ill because of the loss of fluids into the peritoneal cavity, dehydrated, toxic with the drawn in cheeks, then tongue is dry and coated with bright eyes. So it is called Hippocratic facies. I think in textbooks you can find it, either you can Google it and see Hippocratic feces, the look of the patient because of the sunken eyes and dehydrated gut face, and the tongue is dry coated and but bright eyes. The features of hypovolemic and septicemic shock, such as feeble thready pulse, cold peripherals, shallow respiration, high grade fever, and persistent hypotension are also present. Close abdominal distension, guarding, rigidity, abdominal tenderness all over suggest generalized peritonitis. The guarding and rigidity initially in the epigastrium, but now all over the abdomen. Then dullness over the flank because of the fluid accumulation. Then obliteration of the liver dullness as a result of collection of escaped gas under the diaphragm. Then silent abdomen because of the absence of bowel sounds. Then tenderness felt on the rectum examination. Sometimes fluid from supracolic region slowly trickles down along the right paracolic gutter and collects in the right iliac region. And some causing pain and tenderness in right iliac fossa, which will be mimicking appendicitis. Often slow, small perforations present with the subacute features, but diffuse peritonitis eventually sets in 24 to 48 hours. So totally, the clinical features then presents with a severe persistent pain in the epigastrium initially, then later in the right side of the abdomen as the inflammatory fluid spills along the right paracolic gutter, then finally becomes generalized. So that is a total clinical feature. The pain is sudden in onset in this due to contact of the expelled gastric content with the parietal peritoneum. Pain often radiates to the right scapular region. The pain becomes more on movement. Then tenderness and rebound tenderness is seen. That is a lumbar sign all over the abdomen. Then fever, vomiting, dehydration, oliguria, all other symptoms of related to either shock or dehydration. Then patient seems toxic with tachycardia, hypotension, and tachypnea. Abdominal distension occurs. Then finally, terminal stage, what happens? Oliguria, septicemia, shock, Hippocratic facies. Then all the multi-organ dysfunction syndromes can occur. Investigation. So what all investigation we have to do? Plain X-ray abdomen, erect posture, then shows gas under diaphragm in almost 70% of cases. You can see the gas under abdomen. In 30% of cases, there is no gas in the diaphragm. It may be due to either the gas leak is less than 1 ml or due to previous surgery causing adhesions between liver and diaphragm or sealed peptic ulcer. In case of a duodenal ulcer, complete blood picture and electrolyte study should be taken. Plain X-ray of chest and abdomen in erect posture for the will show the collection of free gas under the right dome of the diaphragm. Then if the patient is unable to stand, left lateral decubitus film can be taken. When in doubt, we have to go for a CT scan. Then in some cases, actually, in like a Chilaiditi's syndrome is the interposition of the colon in front and above the liver. So it can be mistaken for gas under diaphragm in plain X-ray. So it is common in children and in elderly. So we have to confirm that also, that it is not the interposition of the colon is in front and above the liver is not there. Then in case of USG also we can get free fluid and some gas can be identified, but it is not a confirmatory. Then blood urea, serum creatinine, total count, electrolytes are helpful. So it is very sensitive investigation report. Whenever there is absence of gas under diaphragm, it rules out other conditions like pancreatitis. Then some gastrography in upper GI studies also confirms the perforations. Then differential diagnosis already told, it mimics the symptoms, mimic acute appendicitis, acute pancreatitis, acute cholecystitis, ruptured aortic aneurysm, then myocardial infarction, mesenteric ischemia, pneumonia. All the symptoms can be, we have to rule out. Then treatment, the patient is given advice for admission. Then IV fluids, ringeractate, normal saline or saline is given, antibiotics are given, and catheterization to see the amount of urine output. Then Ryle's tube aspiration, all have to be done. Then emergency laparotomy should be done through the upper midline incision. All infected fluid is sucked out, then perforation is identified and closed with the interrupted horizontal sutures using silk or Vicryl. Then omental patch is placed and fixed with the loose sutures. It is called Trosigram operation. Then peritoneal wash or toileting using 5 to 10 liters of saline is given. Drain is placed and the abdomen is closed. Often it if required with tension sutures. Then drain is removed in 3 to 5 days. During discharge, the patient is advised to avoid alcohol and to take hydrogen and blockers and or proton pump inhibitors for 6 to 12 weeks. After 12 weeks, follow-up gastroscopy should be done. Next coming to, so this was about duodenal ulcer. Now the perforated gastric ulcer. Commonly ulcer in the lesser curve and near the antrum perforates. So near in duodenal it was anterior. Here lesser curve near the lesser curve near antrum perforates. Amount of gas escaped is more than the perforated duodenal ulcer. Malignancy should always be suspected, and also biopsy from the edges is a must. Then because mortality in the gastric ulcer perforation is high, that is 20% mortality rate is there. Commonly they are pre-pyloric imposition. Then primary closure with an edge biopsy is commonly used. Distal gastrectomy including ulcer area is a better option if patient's general condition is favorable. Then posterior gastric ulcer perforation is often difficult to diagnose both clinically and radiologically. Then perforated stomach ulcer. In perforation of stomach ulcer, often undoing of the gastrojejunum or partial gastrectomy may be required. Then dry perforation. Perforated duodenal ulcer sealed by omentum. As you know, omentum is a greater omentum mainly. It is called the policeman of the stomach or abdomen. So what happens anywhere, any leak is there or any perforation chances are there, it will seal that area. So here perforated duodenal ulcer sealed by omentum, and the patient will be okay. He can walk and he is not that much symptomatic. Then vomiting is absent. Rigidity confirmed to epigastric and the right hypochondria. Then these are the different signs in X-ray in perforation. Tupolar sign, that is the crescent-shaped radiolucent under the diaphragm. Then regular sign, that is visualization of both aspects of the bowel wall being outlined by gas on either side. Inverted V sign, gas on either sides of falciform ligament. Football sign, collection of gas at the center of the abdomen like a football. Then triangle sign, gas between the bowel. Because of that, gas in different areas and different signs are seen. So that's all about perforated ulcer, both the duodenal and gastric. Symptoms are similar only the treatment varies. Next, coming to the carcinoma of stomach, that is also sometimes asked for 15 marks and also carcinoma of stomach. So it is a captain of men of death. It is more common in Japan, that is 70 per 1 lakh population. It is more common in males and decreased incidence in Western world last 4 days because of the use of the anti-infection treatments, that is antibiotics, to prevent the ulcer, H. pylori infection. So like that, it is decreasing in incidence is there, but this decrease is confined to the distant gastric cancers. Incidence of proximal gastric cancer is increasing because the carcinoma proximal stomach is not associated with the H. pylori infection. Maybe because of that, only the distal carcinoma is decreasing. So, what are the etiologies for gastric cancer? Environmental, occupational, or genetic? As you know, any cancer will blame to either environment, then occupation, then genetic or family. Then finally, diet and habits, that is smoking, alcohol, obesity. Then gene mutations are there. Then low vegetable diet with a within diffuse cancers like low vitamin A, sorry, low vitamin A and C. Then consuming red meat. Then inactivation tumor like lead precursor gene. So many genetic factors are there, as you know, in the cancer formation. Then some maybe cases virus also is there. Then occupational, like those who are working in rubber, coal, and all. So some gene mutation also occurs because of that occupations. Then both lowest social status also and highest social status also is there, but difference is there where it is occurring. Distal type is common in lower and higher in proximal cancer, maybe because of the difference in the diet only. Then precancerous lesion, like so many other infections are already, gastritis or pernicious anemia. Then so many other other conditions are precancerous lesions. FAP, like polyps are there. So many oncogenes are there which are getting mutated. Then pathology, gross type pathology, you can see cauliflower type, ulcerative type, and leather body type. All these three types are found. Then classification, intestinal type and diffuse type and others, like that three classification is given. Intestinal type means has got favorable prognosis, that is polypoid, and superficial types are intestinal varieties, common in H. pylori induced. Your gland formation and definite cellular architecture are the features. Synchronous, polypoid, and superficial types are also common. So these are according to the types of the tissue in the intestinal, it is formed. Then diffuse type means here poor prognosis, that the common in blood group A, then familial type, young people and females, is usually poorly differentiated. So the differentiation is poorly, that is called it is diffuse. Then signate type with a early gastric wall penetration and both submucosal and subserosal lymphatic spread. Then Lenitis plastic, that is the last one, it is ulcerative growth without gland formation is also common. Then other some unclassified types are also given. Depending on the depth of invasion, that is early gastric cancer is defined as the involvement of mucosa or submucosa only or without involvement of the lymph node. So it can be classified as according to the Japanese classification, protruded, superficial, and excavated. So according to the involvement of mucosa or submucosa. Then advanced gastric cancer is defined as involvement of muscularis or serosa with or without involvement of the lymph node. That is Borman classification. Stage 1 means single polypoid carcinoma. Second means ulcerated carcinoma with clear-cut margin. Then third, ulcerated carcinoma without clear-cut margin. Then diffuse carcinoma and unclassified. Coming to the spread, I mean, whenever you are explaining a carcinoma, you have to explain the spread. So first of all, direct spread. Directly, it will spread to adjacent structures like pancreas, mesocolon, colon, liver. Then lymphatic spread. Spread occurs by permeation and embolization through the lymphatics to subpyloric, gastric, pancreatoduodenal, splenic, celiac, aortic, and later to the left supraclavicular lymph node. choices sign is explained where the viscous lymph node, that is in the supraclavicular region, the lymph nodes are enlarged or palpable. So that is indicating the abdominal malignancy or the stomach malignancy, it is indicated. This is called Troisier sign. Then retrograde spread to the mesenteric node of small and large bowel can occur, which signifies poor prognosis. That is lymphatic spread. Mostly it occurs late only, so it is poor prognosis. Then blood spread, it occurs to liver. It is the commonest, causing multiple liver secondaries presenting as a multiple hard nodules with amplification due to central necrosis. Later, the lungs and bones also get involved. So metastasis through blood, liver, lungs, and bones. And finally, transperitoneal or transcelomic, it is called. It can cause peritoneal seedlings, so small buds or seedlings of the cancerous cells leading to ascites, and also it can cause Krukenberg's tumor in the ovary in menstruating age groups. So it is commonly seen in colloid carcinoma of stomachs. Actually, our peritoneum is not a closed one. It is open near the fallopian tube. So near from the peritoneum, near through the fallopian tube, it is reaching the ovary. So that is called transperitoneum or transcelomic. Between some cavity it is happening. So it is called transcelomic. Next, coming to TNM classification, we will be knowing T means tumor, the primary tumor. T0, no evidence of primary tumor. T1 as IS is the in situ. Then T1 is the invasion of the lamina propria or submucosa. T2 is the invasion of muscularis propria and subserosa. T3 is the penetration of serosa. T4 is the into the adjacent structures. Lymph nodes 0, no regional lymph nodes. 1, involvement of the perigastric nodes within 3 cm of the tumor, that is 1 to 6 nodes are involved. Then T2 means involvement of perigastric nodes more than 3 cm or involvement of left gastric, splenic or celiac or hepatic nodes, that is 7 to 15 nodes are involved. And N3 is greater than 15 nodes are involved. And metastasis either to liver, lung or bone metastasis. Then leather bottle stomach, that is also asked for 2 mark, 30 mark question. So it is an aggressive diffuse type of carcinoma of stomach wherein there is enormous proliferation of the fibrous tissue involving submucosa of the stomach, which is thickened. So pearl giving a pearl appearance, mother of pearl appearance, but mucosa looks fine. So in between, that mucosa is okay, normal, but beyond that, submucosa is getting affected. So only it is getting like thicker layer. So it is leather bottle stomach. It is type for gastric carcinoma. Clinical features are loss of appetite and weight. Later, mass may be palpable from the body of the stomach. Investigation, we can get a small size stomach in the barium because of thickness of the submucosa. Then endosonography is also diagnostic. Treatment, total gastrectomy with esophageal jejunal anastomosis. Prognosis is poor. It may be occasionally localized linitis plastica in pyloric angle, which is better operable. Next, one more, that is colloid carcinoma of or stomach. That is common, 6% common among all gastric cancers, wherein the tumor cells contain a colloid, which is histologically typical, signifies poor prognosis and more common in women. Asymptomatic in the early gastric cancer and often in cancer of body of the stomach. Non-specific symptoms, that is indigestion, vague epigastric discomfort, constant non-radiating pain, which is not related to food intake. And specific symptoms depends on the site of the tumor, obstruction, dysphagia, mass, etc. Metastatic disease, that is liver secondaries, ascites, secondaries in the ovary, rectovesical pouch or umbilicus. Anywhere metastasis can occur, the supraclavicular nodes, lung, bone, etc. Then unusual presentations like acanthosis nigrans or the Irish nodes in the axilla is also seen. Clinical feature, so totally recent, mostly the patient is related to stomach. What happens? Loss of appetite and the weight loss will be there. Early satiety little bit only they can eat. Early satisfaction is not there. It's early, just after a little bit of take of food, they feel full. Then fatigue, microcytic hypochromic anemia because of the iron deficiency. Then upper abdominal pain, vomiting with features of gastric outlet obstruction. Then some tests are the auscultoperfusion test that will be positive. Then suction splash to be checked in within 4 to 6 hours of empty stomach. Then mass abdomen, mass in the pylorus lies above the umbilicus, which will be nodular, hard with impaired resonance, mobile, moves with the respiration, all borders well cleared out. Then dysphagia with a mass in the upper epigastrium. When it arises from the body of the stomach, it may present only as a mass abdomen. Along with the jaundice, liver may be palpable with the secondaries. When the metastasis is there, liver may be palpable and jaundice will be present. Then ascites and Troyer's sign already I told, supraclavicular lymph nodes are enlarged in case of abdominal malignancies. Then Blumashell, that is rectovesical secondaries on per rectal examination, you can see rectovesical tumors we can see. Then positive Troyer's sign, that is a migrating thrombophlebitis, mostly seen in carcinoma of pancreas, but along with that here also we can see anemia, cachexia, then hematemesis malignea. Occasionally, carcinoma stomach can present as a perforation to begin with. Then rarely secondaries with a silent primary in stomach also occurs. Secondaries in umbilicus, that is also that is called as Sister Joseph's um, nodules, that which is spreading through the ligamentum teres. Then cutaneous secondaries or Cucumet's tumors also can be diagnosed. Then differential diagnosis, acid peptic disease, pyloric stenosis with a gastric outlet obstruction, gastritis, pancreatic mass, and then a transverse colon mass. Any carcinoma we have to rule out. Advanced fixed stomach mass may mimic retroperitoneal or nodal mass also. In investigation, HP obviously it will be less than hematocrit, all the values you have to uh, rule out. Then barium meal, irregular filling defect we can see. Single contrast barium studies, then double contrast barium studies in the detection of gastric cancer, it is important. Then barium meal findings, barium meal, we can see the findings like a irregular filling defect, loss of rugosity, the rugae formation, that wrinkles in the normal stomach will be lost. Then delayed emptying, then dilatation of the stomach in the carcinoma pylorus, decreased stomach capacity in limitis plastica. Then margin of the lesion projects upward from the ulcer, lesion or the lesion in the gastric lumen. It is called Karman's meniscus site. Then gastroscopy with biopsy. Then endosonography, that is EUS, is useful to detect the involvement of the layers of the stomach, nodal status, and to define whether tumor is in early stage or the advanced stage. All five layers are visualized as alternate hypo and hyper echoic regions. It gives 90% of accuracy. Then USG to see the liver secondaries or ascites or nodes in the ovaries. But it is not sensitive as EOS or CT. But first of all, everyone will prefer USG only. So after that only we'll go for CT. Then liver function test in thrombin time. Secondaries in the liver can cause hepatic dysfunction, liver cell failure. Then enlarged hepatic node can compress CVD, common bile duct, and cause obstructive jaundice also. Open FNAC from the left supraclavicular lymph node. I already told Rosier's sign. So left supraclavicular lymph node, which is significantly palpable. Then laparoscopy to find out the stage of the disease. CT scan abdomen and CT thorax in proximal tumors to see the size, extent, infiltration, and the status and secondaries and operativity. Then so many other tests, tetracycline fluorescence test for the gastric cancer, because these cells take up tetracycline given orally, which become yellow in color. So under UV light, it shows yellow fluorescence. So it is used as testing gastric cancer. Then the tumor markers CA72-4, to evaluate the relapse. Then CEA, then CA 19 9, CA 12 5 are all other markers of abdominal malignancy. Then laparoscopy to see the peritoneal seedlings and to take peritoneal biopsy. Then combined PET and CT scan is also useful to evaluate the metabolic, physiologic, and functional activity. It is mainly useful to identify recurrent gastric ulcer. Then sentinel node biopsy, that is technetium, is injected during gastrectomy. It is got sensitivity then but not widely used. Already told a Sister Mary Joseph nodule, that is Sister Mary Joseph. She was a head nurse of William Mayo doctor. So he first noticed a nodule in the umbilicus, which was associated with the advanced malignancy. So it is named after her. That is Sister Mary Joseph nodule. Presents as a firm red non-tender nodule results from the spread of the tumor within the falciform ligament. 90% of tumors are adenocarcinomas. Commonest primaries are stomach and ovary. So either primary carcinoma in the stomach and ovary, we can find in the advanced stage a nodule in the umbilicus. That is called Sister Mary Joseph nodule. So that's all about the symptoms or the carcinoma. Then coming to the treatment. So when the diagnosis of the carcinoma it has been made, so we have to first go for a laparotomy. We have to cut open and see how much the chance of survival is there, how much the stomach can be rescued, or how much we need to do recession. Okay, so it's like some contraindications of laparotomy are that who is obviously unfit for to stand the operation, maybe elderly or any other other chronic illness are there, or in whom there are definite signs to show that the disease has advanced beyond the scope of any operation. So in that case, we don't need of simply doing a surgery or operation or laparotomy. So already the disease have advanced beyond the scope of operation. In that case, no need to go for laparotomy. So such which are the signs that growth is palpably fixed in situ. When we are palpating, the growth is that much fixed, it is not moving. Then palpable metastasis even in the pelvis and the peritoneum with or without ascites. Right? There is palpable metastasis already. We are suspecting or we are sure about the pelvic metastasis. In such case, no need of laparotomy. Then multiple metastasis in the liver. That is already with the CT or in we can have USG even. We can find the metastasis. That is solitary metastasis may be resectable, but in case of multiple, we have to understand that it has advanced to the further stages. Then palpable metastasis in the left supraclavicular lymph node, troisier side. Then jaundice, liver has been infected or involved. Then evidence of the metastasis in the lungs and bones. So all the metastasis is there, no need of going for laparotomy. We can go for palliative care, but otherwise only we need to emergency. We have to go for a laparotomy. So first of all, we need to open the abdomen, then abdominal. Mostly, in case of upper 1/3 of the stomach, we can go for abdominothoracic approach. Otherwise, we prefer abdominal approach only. So once the abdomen is opened layer by layer, all the skin, I think you will be knowing appendicitis and all. You will be knowing all the layers of the skin, so muscles, how you are opening the abdomen. It definitely. So once a peritoneum is open, we have to a definite plan is made out on the extent of the growth. Okay, so first we have to isolate that stomach and see how much the part is extent is of the growth is that. Then contraindications to radical surgery. So fixation, if the growth is fully fixed to the surrounding viscera, that is growth is fixed to the pancreas or posterior abdominal wall, then fixed to the with the fixity of the involved lymph nodes. Lymph nodes are not moving; it is fixed to the surrounding tissue. Then presence of secondaries all over the peritoneal cavity. Then presence of multiple secondaries in the liver. Then only we have to do a palliative surgery. Okay. Otherwise, we have to go for a radical operation. What do you mean by radical operation? It means a recession of the growth with at least 1 inch of the surrounding healthy tissue. So all the affected part along with 1 inch of the surrounding healthy tissue of the tissue or the healthy wall of the stomach. That 1 inch outside the palpable margin of the stomach should be resected, and together with all the lymph nodes draining the stomach. According to the position of the growth, radical gastrectomy may be either total radical gastrectomy or upper radical partial gastrectomy, then lower radical partial gastrectomy. So first of all, total radical gastrectomy. So mainly indicated when there is the involvement of middle part of the stomach and or the whole of the stomach. So in that case, we do a paramedian incision and the liver, sorry, the spleen with the hilar lymph node, the spleen vessels, tail and body of the pancreas. So near to stomach only, pancreas and spleen is there, right? So it is mobilized from left to right. Then the operation is retroperitoneal. That is now from the stomach with the both lesser and greater omentum is resected. The lymph nodes around the celiac axis is removed before beginning gastrectomy. The left gastric artery and the right gastric artery should be ligated to check the bleeding. Then lymph nodes of the supra and the subpyloric groups also removed with the ligation of right gastroepiploic artery. After excision of the whole stomach, the cut edges of the pancreas is also closed with the suture. Then the continuity of the alimentary canal is restored with the esophagogynostomy. It is called ROX EAY type. So esophagogynostomy is done in the case of total radical gastrectomy. So full stomach is being excised. Okay, the whole stomach is excised and esophagus is pulled a little bit down and jejunum is pulled upward, and then esophagogynostomy is done. By this procedure, regurgitation of bile and pancreatic juice into the esophagus is prevented. Then, before closure, a drain is drain is inserted up to the pancreas, and the other end is brought out through a separate stab incision at the subcostal region. So that is about total gastrectomy. Then upper radical partial gastrectomy, it is indicated for the growth involving the cardia and the upper third. So in case of upper part is involved or the lesion is there, the pyloric end of the stomach is preserved and is anastomosed to the esophagus. A pyloroplasty is usually performed to prevent post-vagotomy retention. Then lower radical partial gastrectomy. This operation is indicated for carcinoma of lower one third. So lower one third of the stomach. This operation is ultimately completed with gastroduodenal. So lower one third means what happens? The lower half of the gastric part is removed. So half of the upper half is there. Upper half of the gastric is there, and the duodenum is healthy. So gastroduodenal anastomosis, which is called Billroth 1, partial gastrectomy, or if first part of the duodenum is also should be removed, means so gastric part, half of the lower half of the gastro and the upper part of the duodenum is have to be removed, and in that condition we have to anastomose the jejunal anastomosis, that is Billroth 1. I will be explaining in detail. Then total gastrectomy can be performed when the upper one third of the stomach is unaffected, to take advantage of a small remnant of the stomach to anastomose with the jejunum for better anastomosis than esophagogynostomy. So that is all radical and all the partial gastrectomies. Next, coming to the palliative operations. So, as you know, the advancement is very fast. So, when the growth is come out to be not suitable for a radical operation, in that case, you have to go for a palliative operations. That is palliative recession of the growth. Only the growth is removed whenever possible. That mass can be resected together with a healthy margin of a gastric wall. So only that wall region along with the lesion is removed. But mostly the with that symptoms, mostly there may be progressing to the lymph nodes. Everything will be that much progressed or metastasis is there. So in that case, 1 or 2 years only the patient may survive. Then antral exclusion operation, that is for fixed adherent or irremovable growth. Okay, that is that much fixed it is, involving distal or antral or pyloric portion of the stomach, which defies a recession. Antral exclusion combined with anticolic gastrojejunectomy is indicated. So in I think no need to go into deep, only the name antral exclusion operation is enough. Then gastrojejunectomy for irremovable malignant lesion of the antrum and the pylorus associated with the obstructive symptoms, anterior or anticolic gastrojejunectomy may be indicated. The anterior operation is preferred as the tumor shows a tendency to invade the omental bursa posteriorly. Then operation is simpler and rapidly performed. Then jejunostomy, when the cancer of the stomach invades the stomach wall so extensively, it renders the performance of the gastrojejunostomy or gastrostomy impossible. In that condition, jejunostomy can be tried for palliation. So, same like a rubber catheter is inserted in the cavity of the jejunum, followed a curve goes through seromuscular layer, and one we have to, it is a palliative. Obviously it is done in the case of incurable cancer, or it will last only for 1 to 2 years. Then gastrostomy in case of irremovable cancer of the cardiac end of the stomach, in which esophagus and gastrostomy or esophagojejunostomy is not feasible. Gastrostomy may be tried, but result of gastrostomy is very never very encouraging. Then SEMS, that is self-expanding metal stents in pyloric and duodenal disease. So in case of strictures of the pylorus, because of the lesion in this resulting in the stricture of pylorus and duodenum, we can go for a stent, metal stent, that is called SEMS, self-expanding. So when the bolus is coming, it will be self-expanding. Okay, so that is called self-expanding metal stents. Then complications, radical gastrectomy is a major surgery, and it is having complications also, that is leakage of gastrojejunectomy, mostly rocks and by reconstruction. Mostly it is managed conservatively because it is mainly saliva and ingested food that leaks. Then a fistula from the wound or a drain site, it is a good practice to perform a water soluble contrast swallow at 5 to 7 days after operation to determine whether the anastomosis is intact. So even after procedure, we have to recheck whether any leak is there. Leakage of the duodenal stump also can occur. Then finally, all the surgically we can do, but radiotherapy and chemotherapy is not having much role here, as there are number of radiosensitive tissues around, so which limit the dose of radiotherapy. But as it gives a palliative role because of the painful bone metastasis, it will be good. Then chemotherapy also, but better than radiotherapy. But cisplatinum or 5-fluorouracil or epirubicin are can be given as a chemotherapy. So that's all about the CA stomach. So I think already we understood all the, mainly the treatment only you have to cover more. That is total radical gastrectomy, upper radical partial gastrectomy, or lower radical partial gastrectomy. So radical means the recession of the growth with at least 1 inch of the surrounding healthy tissue of the stomach, together with all the lymph nodes draining the stomach. So there is total radical gastrectomy, full of the full whole of the stomach is excised, and esophagojejunostomy is done. I will show the picture. Then a partial gastrectomy also. I am going to detail it. So that's all. about the CA stomach. So next coming to gastrectomy. So in this picture, Billroth 1 and Billroth 2 is explained. You can see how the Billroth 1 means gastroduodenostomy. Then Billroth 2 means gastrojejunectomy. That is how the procedures are done, operations are done. First of all, Billroth 1. So Billroth 1 is done for mainly benign conditions. Here, along with the partial gastrectomy, gastroduodenostomy is done. Billroth 2 is done for carcinoma stomach. After that is a benign condition, mostly will go for duodenostomy. Is if carcinoma is there, means what happens? Mostly it would have expanded till the pyloric end. Okay. So, first of all, after partial gastrectomy, gastrojejunectomy is done and the duodenal stump is closed. Then lower radical gastrectomy is done in early carcinoma pylorus, lower radical gastrectomy. Here, along with the growth and the proximal 5 centimeter of the stomach, omentum, a lymph node, spleen with the tail of the pancreas are removed, and Billroth 2 anastomosis is done. In growth of upper part or esophagogastric junction, the upper radical gastrectomy is done with the esophagogastric anastomosis. In some cases like Lenitis plastica, total gastrectomy along with the esophagojejunal anastomosis is done. So coming to the partial gastrectomy, which is the indications for the treatment of duodenal ulcer when the maximal acid secretion is more than 50 milliequivalent per liter. So Billroth 2 is done, preferred, because the duodenal bulb at times becomes scarred and it may be difficult to mobilize it to unite with the proximal stomach. So in case of duodenal ulcer is there, we will go to Billroth 2. In patient with a duodenal ulcer with a lower acid secretion, the distal 1/3 of the stomach may be excised. So that is the indication. Then in case of benign gastric ulcer, as I already told, Billroth 1 is still the operation of choice. But the conditions are the unscarred and mobile duodenum can easily be united. So there should not be any scarring of the duodenum, or duodenum should be mobile. It should not be fixed. So in that case, it can be easily united to the proximal stomach redundant. Then in case of high lesser curve ulcer, it can be excised with the tongue of stomach, preserving longer, greater curvature for the gastroduodenal anastomosis. Then when the gastric and third point, when gastric and duodenal ulcer coexist, in that case, Billroth 1 reconstruction give equally good result. If the duodenal bulb is having scarring, in that case, Billroth 2 is done. In case of gastroduodenal bleeding, partial gastrectomy, so gastroduodenal is there, means we'll go for gastrojejunectomy. So then benign tumors, already told, gastrectomy, Billroth 1 is done. So next coming to the techniques of Billroth 1 gastrectomy. So what do you mean by that? This operation can only be performed when the duodenum is wide, mobile, not scarred, adhered, and or narrow. So all these are not there in that condition. So means duodenum is normal. Okay, and that in that condition we can go for Billroth 1 gastrectomy. So the stomach and the first part of the duodenum are mobilized. The mobilization is more conveniently by Kocher's method, that is incising the peritoneum on the lateral aspect of the duodenum. But the lesser curve is free of the omentum, only 2 centimeter proximal to the ulcer. Then duodenum is divided between the clamps just distal to the pylorus. Then distal cut end of the duodenum is covered with a gauze and kept aside for future anastomosis. The transection of the stomach is carried out with the aid of 2 pairs of clamps applied at an angle to each other. The lower clamp is so applied that it covers that portion of the stomach which anastomoses with the duodenum. So according to that, the lower portion of the stomach is applied a clamp. Then while upper clamp is so placed so as to Resect up to 2 centimeters above the ulcer. Then portion of the stomach held by upper clamp is closed with a over and over stitch, including the clamp. The clamp is withdrawn, stitch is gradually tightened. Then a seromuscular stitch is applied to invaginate this layer. Thus, a new lesser curvature is made. After that, we already removed cut the duodenum and kept it aside now. So that duodenum is attached to the distal cut end of the stomach. So make sure that they come to each other without any tension. There is no pull. Then a seromuscular stitch is applied on the posterior wall of the two viscera back and forth while the bowel ends lie apart. Then the stitches are then tightened serially to draw the seromuscular layer in contact. Now join together the stomach and duodenum using a continuous all-caught suture. First, the posterior wall is joined. Care must be taken at the upper corner where there is new lesser curvature. This all-caught suture is continued to unite the anterior walls of the two viscera. So, from the posterior, it is stitched through to anterior wall. Anastomosis is completed by using the seromuscular stitch for anterior walls of the two viscera. Then after that post-operative nasogastric tube is always left in situ. Then 2 hours hourly section and intravenous infusion are continued. Then dietary regime, more or less like post-operative care of gastrojejunostomy operations are done. Then take small frequent meals due to greatly reduced size of the stomach. And gradually the stomach attains a normal conduct to times. So you can see the picture. First is the normal anatomy. Then you can see first we will do the recession of the stomach. In that lower, you can put the clamp near the pyloric region. So the duodenum is cut apart. Then recession of the stomach completed, removed, and it is pulled. The duodenum is pulled towards the gastroduodenal gastric region, and the anastomosis is done. So that is gastroduodenostomy. Okay, the anastomosis between duodenum and the stomach is done. Next, coming to the technique of Billroth 2 or Polya Billroth gastrectomy. So in this case also, the right upper paramedial incision about 20 centimeter long and or through a midline incision skirting the umbilicus. Then the peritoneum is opened to one or other side of the falciform ligament. The stomach and duodenum and other viscera are thoroughly examined. The stomach is drawn out of the wound. Then the probable extension of the recession is estimated, and Hall is first made through the gastrocolic omentum in an avascular area to the left of the left gastric gastroepiploic vessel. The greater omentum is detached from the stomach by division between successive pair of artery forceps applied close to the greater curvature of the stomach. It is an advantage to commence the division from upper left side as additions at the least at this side. So, first of all, we will do an incision, that is right upper paramedian incision. Then the upper the laser incision is till the peritoneum is open. Then stomach and duodenum is examined. All other viscera, spleen, pancreas, everything is examined. Then stomach is drawn out of the wound, and we have to know the probable extent of the recession. Then greater omentum is detached. Then once while the division is started, first we have to ligate some short gastric vessels or gastroepiploic vessels to arrest the bleeding. Then we should not damage the spleen. Then gradually the gastrocolic omentum is detached along the greater curvature. Then the right gastroepiploic vessels also ligatures are done. Then now attachment of the lesser omentum or detached from the lesser curvature of the stomach gradually towards the left between the pair of artery forceps. Then right gastric vessels are also identified and ligated just above the duodenal bulb and pylorus. So just near the left gastric artery, we have to stop the dissection. Then posterior surface is, of the first part of the duodenum is dissected from pancreas sharply or bluntly according to the condition. Then duodenum is freed for at least 1 centimeter distal to the ulcer. At this site, the gastroduodenal artery may have to be lubricated, and but we have to preserve the common bile duct and the hepatic artery. Then two occlusion clamps are applied side by side at the site of proposed section of the duodenum. Then area is now well separated from the rest of the abdominal contents with the box. Then sucker machine is switched on. The duodenum is divided between the clamps and opened duodenum is sucked so that no intestinal juice can contaminate the in abdominal content. So suction is done that so that intestinal juices are not remaining in the duodenum. Then proximal curtain held in a clamp is covered with a piece of gauze and turned towards the left side of the wound. Then closure of the duodenal stump is done. Mostly, it should be very meticulously as the duodenal leakage is the most serious post-operative complication. So, we are dividing the duodenum and as it is being kept as a stump. So, that leakage should be prevented so that the stump is closed correctly. Conventionally, it is done by all four through and through suture and seromuscular lumbar suture to invaginate the first layer. Then we have to invaginate deeper, that is to kill the mucous membrane completely. Then a second invaginating suture or a purse string suture is made to invert the stump within, like in appendicitis, you have seen purse string suture. So like that inversion of the stump, we are using purse string suture. So we have to better cover the stump with a peritoneum. Okay, a layer of peritoneum is used to cover the stump so that there is less chance of leakage. So by means of a suture catching the leakage stumps at the right gastric and right epiploic vessels, the anterior wall of the duodenum and the peritoneum over the pancreas. Then after that, the stump is left as a closed stump. Then stomach is now held up with the help of a clamp so that the left gastric vessels are tense. With the fingers, the pulsation of the left gastric artery is felt where it reaches the left lesser curvature and below the cardia. Then the vessels are carefully dissected, doubly clamped, then divided and ligated. Select the line for division of the stomach to remove the distal half, the 2/3 of or 3/3 according to the circumstance. According to lesion, how much portion we have to remove the stomach, we have to decide. Then select the line of for division. Then loose tissues just above the proposed line of transection are trimmed off from the greater and lesser curvature. After that, an opening is again made in the transverse mesocolon. Then a proximal loop of jejunum. So, we are going to anastomosis with the gastric and jejunum. So, a proximal loop of jejunum, we are taken out through the transverse mesocolon. Okay. So, that proximal loop of jejunum is brought upward through this. Then the loop should be as close to the duodenojejunal flexure as possible. So the loop should be comfortably placed alongside the side of the stomach so that the proximal portion will correspond with the lesser curvature and the distal portion to the greater curvature of the stomach. The two pairs of the tissue forceps are applied to the two ends of the proposed anastomotic segment of the jejunum. And occlusion clamp is applied across the stomach just proximal to the level of the section, while a similar clamp is applied to the anti-mesenteric fold of jejunum. So after that, seromuscular suture is used to do the anastomosis. Then to unite the adjacent surface of two viscera. Then a Peyer's crushing clamp is applied to the stomach distal to the suture line. Now all the abdominal contents are pushed inside the abdomen and covered with the two mops. The stomach is divided proximally to the crushing clamp and the whole length of stoma is to be utilized. The jejunum is incised 1 centimeter away from the suture line. When the sides of the viscera are exposed, they are well sucked and thus avoid abdominal contamination. So after that, classical 4-layer anastomosis is done. So you can see in the picture, Bell-Roth 2 gastrectomy, how it is done. The normal anatomy you can see in that the second picture, the recession of the stomach is done. Then after that, gastrojejunal anastomosis, how it is done. Okay, the closure of the duodenal stump is also in the last lower side. You can see the closure of the duodenal stump, and then gastrojejunal anastomosis is done. So that is, I think, you understood how the jejunum is brought near the lower part of the gastric and stomach, and it is anastomosed. And the duodenal stump will be remain as a stump. It is closed even with a layer of peritoneum. Okay, so that is Bell-Roth 2 gastrectomy, mainly indicated in chronic benign gastric ulcer, benign tumor of the stomach, carcinoma stomach, stomal ulcer, bleeding ulcer, leiomyosarcoma, then gastric lymphoma, many tears disease. All these are the indications. Then finally, all the layers for the closure of the even the transverse mesocolon also should be closed. Okay. So next, the complication. There may be bile leakage, then duodenal blowout will be the gastric fistula formation, dumping syndrome. All these are the complications. Then I already explained previously the Roxane E Y anastomosis. That is how the esophagus, okay, or the duodenal stump, the Y shape, how it is coming. You can see the distal gastrectomy. So gastrectomy is done, but after that, you can see the duodenal stump little bit lower. So near the pancreas, where the opening of the pancreatic and bile duct are there, common bile duct are there. So from the we are bypassing. Okay, so that there is it will not regurgitate. Okay, so in that case, we will be cutting the jejunum below and making it opening near the duodenum. So duodenum, after duodenum, it is cut near the jejunum, and jejunum is also having a stump opening. So like that. Okay. So that is Y shape. It is called. It is called gastrojejunectomy, and gastrectomy is done, and the Y shape anastomosis is done. Okay. So that is also gastrectomy. Next, coming to one more operative procedure, which is used in the peptic ulcer, vagotomy. It is also important in exam point of view. So I think already I have given some pictures regarding that in previous class. So here mainly indicated it is a done along with a drainage procedure. Okay, that is a pyloroplasty or like that drainage procedure where the vagus nerve is cut. Okay, mainly this indicated in duodenal ulcer, and it is also alone is performed in case of anastomotic ulcer following gastrojejunectomy and partial gastrectomy. So three types are the truncal vagotomy, selective vagotomy, and proximal gastric vagotomy or highly selective vagotomy. So truncal means what? Both the trunks. You can see in the picture truncal. So both the trunks of the you can see the square picture in the picture or rectangle where the cut is given. That is, both trunks are of the vagus nerve are transected. So almost 5 to 7 centimeters of the nerves are excised. So this technique is also called vagectomy. Almost the nerve is fully removed. So it is called vagectomy. Then selective vagotomy means all the gastric fibers alone. So side fibers are so only the gastric fibers of the vagus nerve, keeping the hepatic and celiac branches. So which is going to the other side, that is the hepatic and the celiac branches are preserved, but the gastric fibers are removed. Then proximal or gastric vagotomy or highly selective vagotomy is designed to denervate the acid secretory part of the stomach, keeping the vagal supply to the alkali secreting gastric antrum, and other abdominal viscera. This is the mobility of the stomach. So mobility is not affected, only the secretory part is affected. So like that, only the proximal or high, the which is supplying the parietal cell is selected. Okay. So here also midline or left paramedian incision is done. Then left lobe of the liver is mobilized by dividing left triangular ligament. Then position of the esophagus is guided by the presence of nasogastric tube. The peritoneum over the abdominal part of the esophagus is transversely incised, taking care not to damage the inferior phrenic nerve. So beneath the fascia of the esophageal ligament, this is also divided in the same line. Then the finger, we can feel the posterior mediastinum. Then the lower 3 inches of the esophagus is mobilized and retracted downwards. Then the assistant is asked to pull the stomach down when the tense anterior trunk will be seen lying on the anterior surface of the esophagus. The posterior trunk lies some distance separate from the esophagus. So 5 to 7 centimeters of the both trunks are excised and the remaining ends are tied with a fine silk. So ligature is made without to avoid bleeding from the ascending esophageal varices, which runs along with the nerves. Then horizontal deficiency in the hiatus is closed with a non-absorbable switch. But there are complications like gastric retention. For this, we will do like pyloroplasty also, then diarrhea, then pseudoachalasia, recurrent ulcer. Then coming to the selective vagotomy. So selective vagotomy means that is the hepatic branches are identified in the upper part of the lesser omentum. An incision is made through a vascular area below them to reach the lesser sac. Then dissection is started along with the anterior vagus nerve in the lesser omentum downwards to find out all the gastric branches, which is ligated and divided one by one. And for posterior selective vagotomy, an incision is made through the peritoneum at the ankle of his. Then right index finger is passed through the hall to search or reach behind the gullet, and the right thumb is passed through the hall made in the lesser omentum. Then we can find the posterior vagal trunk. The tissues behind the posterior vagus nerve are burst through, and a tube is inserted to include the gullet and the vagus. Then after that, to save the care should be taken to save the celiac branch. And then with the right index finger, the posterior trunk is pushed posteriorly, and tissue in front of the finger are lightly tissues in front of the finger are very minutely dissected to secure the gastric branches of the posterior vagus nerve. They are ligated and divided. Last part of the duodenum is now thoroughly exposed to clear any additional fibers which may be left behind. So that is how selective vagotomy is done. Then proximal gastric vagotomy or highly selective vagotomy. So here differs from that the point of preservation of the nerves of Latergit, which runs along with the lesser curvature, so which supply mainly antrum and the pylorus. So mobility or the food movement downwards is protected. Okay, only the gastric secretion is affected. So these nerves are preserved and prepared from separated from the posterior gastric branches by passing forceps to the lesser omentum to the left two of the nerve of Latergit, close to the gastric wall about 3 inches from the pylorus. It is very convenient to say the posterior nerve of Latergit through the lesser sac, which is entered through the greater omentum at the middle part of the greater curvature. So that is all. Then even a lesser curve seromyotomy is also done in laparoscopic procedure. Then pyloroplasty, just a few points at pyloroplasty. It is also a drainage operation. Sometimes it is also asked for 3-mark questions and all. So pyloroplasty, it is indicated in an uncomplicated duodenal ulcer. This operation along with the vagotomy is probably the operation of choice. And in case of gastric ulcer, along with the vagotomy may be performed provided the ulcer is excised and biopsied. Then in peptic perforation, the patient is not sufferer of the duodenal ulcer, and when the patient's condition is not too grave to perform this operation, pyloroplasty along with the vagotomy is not only a life-saving preventive measure but a curative operation also. So how the incision is made through all coat of the anterior wall of the pyloric canal, midway between the greater and lesser curvature. Then contents of stomach and duodenum are aspirated, and the inner wall is inspected. Then if the ulcer is found very close to the incision, it should be encircled and excised. Then using a tissue forceps, apply to the upper edge and one at the lower edge. Both the middle push points are incised. Then the two pairs of the forceps are now pulled apart so that the proximal and distal end of the incision approach to each other and the defect become vertical, thus widening the pyloric canal. So after that, the defect is closed using all-coat suture. So it is actually repair of the pyloric canal so that it is widened. Okay. So leaving a vertical suture line. So that is all about the and after that the walls are sutured. So that's all about all the surgical procedures related to